I'm Dr. Balaji, and then it will be a brief session, I promise you. Basically, I'm going to talk regarding the extended DAPT in ACS and post-PTCA setup. We all know that now after ACS and PTCA, we are right now giving the DAPT for 1 year in most of the cases, in all of the cases as the recommendations goes by. So I'm here to discuss basically, is there any role for the extended DAPT beyond 1 year? And where does the ticagrelor, which we all use in most of the times in most of the patients of the PCA, where does it fit in? Yeah, we all know that the ACS is the tip of the iceberg, and then subclinically we have the plaques which are yet to rupture and then which are quiescent, and there is a persistent activation of the platelets in most of the ACS patients, and there is a vascular inflammation. I used to think that once we treat a patient with ACS or a PCA for 1 year, and then the risk stops there, and there not be any kind of risk in which extends beyond that. Surprised to see that as the years progress beyond the ACS 1 year or PCI, the risk increases, accumulates, accrues, and then it actually increases. So this forms the basis for the extended DAPT. Along with there are a subset of patients who are at high risk. We all know the multivessel disease patients carry a high risk of stent thrombosis and events when compared to single vessel disease. We all know by the 1 year mortality rate in single vessel disease and double vessel disease and triple vessel disease, it increases exponentially. Either in STEMI or non-STEMI, in STEMI, the multiple disease carries a mortality of almost like more than double of the single vessel disease, and also the non-STEMI, the survival rates are cumulative survival rates are less than the single vessel disease. Diabetes we know is a separate subset where the patients have a high risk of thrombosis, they have more activated platelets, they have higher inflammation, so consequently they are more prone for ACS. So especially the diabetes with the non-thrombosis are a prior ischemic event, they are at the highest risk of events. So now we know there are some subset of patients like the multivessel disease, the diabetics, and the patients with prior ACS, and then inherently the ACS patients have unruptured plaques, and then these patients can go on, and an ACS can have a deleterious effects and the recurrence of events as years goes by. These are being dictated by the event rates are dictated by the two things. One thing is the plaque and its composition, and the factors that make the plaque to rupture. We know that the high lipid core plaque with a thin fibrous cap has a high incidence of rupture. We don't have probably much control on them, the inflammation and then the plaque composition. But what we probably can have a control on is the activated platelet or active platelet, or decrease the activity of the platelets, decrease the activity of the platelet aggregation and adhesion. That's where we have control on. We need to always remember this, that the majority of the MIs are caused by the plaques which are less than 50% stenosis. And then with this background of the high risk patients, we will examine how the DAPT has been tested in some trials. Way back in 1996 there was a capital trial which has substituted clopidogrel in the place of aspirin in ischemic events, and has proved to be probably beneficial than aspirin in the ACS subset. Whereas the Charisma trial, which has included 15,000 patients, where clopidogrel plus ASA versus aspirin plus placebo did not fare that well, and actually in a subset of patients of asymptomatic subset, actually the event rates were higher than normal. So the Charisma is some kind of a failure trial where the DAPT is concerned in extended arm. There is a DAPT trial where Voraxapar, which is a PI1 inhibitor, which actually inhibits the thrombin-activated platelet activity. So this is a little successful trial where the thrombotic events has decreased in the ACS patients when the Voraxapar was given. But it is not available, it's available on ESA, then probably will not be talking about it. The two important trials which has come recently, which has set the tone for the extended DAPT, are DAPT trial and the Pegasus trial. The DAPT trial has compared 12 months versus 30 months DAPT post-DS in mixed population of stable CAD and ACS. The patient had some bare metal stents in some subset, and most of them are the DS. And the other trial is a Pegasus trial, where is basically on the background of MI, whether extending the DAPT beyond 12 months up to 30 months, whether this is going to make a difference in the event rate. These are the two trials which I may be discussing now. Before we go into the trial proper, we always should balance the risk of thrombosis with the risk of bleeding. So when you are giving a potentially useful as well as a drug which can cause bleeds, we need to balance this. We know that those patients with increased ischemic risk are patients who present with MI, ACS, MI less than 1 year, and extensive CAD like as a multivascular disease, and patients with diabetes, CKD, and with advancing age. This subset of patients with the increased ischemic risk has to be balanced against the bleeding risk of the patients with women, less body weight, who has bled already, anemia, and then probably who are done chronic steroid therapy or NSAID therapy or a chronic oral antiplatelet therapy. So before we go and then think about external DAPT, we have to balance this risk and benefit. With this, we'll go to DAPT study. DAPT study, as I said, is basically a trial where all the DES patients, all the post-PCI patients were studied whether beyond 12 months, when you give a DAPT, is that useful or not. So, as I said, the patients had both chronic stable CAD as well as the ACS. So, there is after 12 months of DAPT, these people were divided into randomized into two arms. The total number of randomized patients were about 9,900. So, after 12 months, the one arm carried only aspirin with a placebo. The other arm carried aspirin with one of the thienopyridines, that is either the clopidogrel or the prasugrel in this case. So, this is not a ticagrelor arm. So, this patient after 12 months of DAPT, these patients were broadly categorized into aspirin alone in one group with a placebo. The second group had aspirin with clopidogrel or prasugrel. And these people were further followed up after 18 months. That means 12 plus 18 is 30 months. At the end of 30 months, they had a hiatus of 3 months, and then the results were analyzed at the end of 33 months. What are the primary endpoints which were studied? The primary endpoints which were studied was combined stent thrombosis, basically the stent thrombosis, and the second one is that MACE, that is death and myocardial infarction or stroke. So, they studied what is the stent thrombosis rates with the extended DAPT beyond 12 months up to 30 months vis-a-vis the aspirin and placebo, and aspirin with either clopidogrel or prasugrel. And at the end of 33 months, they analyzed the data, and then they found there is a significant reduction in the stent thrombosis. There is a relative reduction of 70% for stent thrombosis, and there is up to 30% of decrease in the MACE in the form of decrease in the overall death rate, and then MI and stroke. And for the MI specifically, there is a 53% decrease in the MI. Significantly, in this DAPT trial, the MI was reduced both at the stent and other locations. This is where I want to probably stress one thing, that we give DAPT not only to decrease the stent thrombosis at the site of stent, the DAPT is going to decrease the event rate diffusely in the overall coronary circulation as well as cerebrovascular circulation. So, the DAPT that we give, as we know that this atherosclerosis is a diffuse kind of inflammation which is active all over the vascular tree. The DAPT is going to decrease the inflammation and events in and around in the whole circulation, in the whole cardiovascular tree, not just at the stent. In this trial specifically, the 55% of decrease in the mortality or MI is because of not with the thrombosis at the stent site but other sites. With this, it also is found to have a little amount of increase in the bleeding rate. The bleeding rates were higher, but fortunately the severe or fatal bleeding were uncommon. The kind of stents which were tested in this trial was about 4 stents were tested, and the patients were on almost all of the stable and accepted medications. So the DAPT trial has proven to us that in patients who had a stenting done, DAPT beyond 12 months up to 30 months were probably effective, and then probably to be given at a little increase in the bleeding, but no fatal bleeding. So with this, that we want to test the ticagrelor in the same kind of setup. Actually, it's not same kind of setup. Whereas DAPT is a post-PCA setup, the Pegasus trial was done in MI patients. It was an MI which was happened almost like an average in these patients 1.7 years before, on average 1 to 3 years before. So before the people were randomized, they had MI 1 to 3 years back. They were at least 50 years or older with only at least one more risk factor. So these patients had MI and at least one more risk factor. What are those risk factors? whether they are aged more than 60, or they had multivascular disease, or they have diabetes, or they have CKD. So the PEGAS trial tested basically extended DAPT in a high-risk group who had a MI in the past. So the 21,000 patients were randomized into 1:1:1 into three categories. Ticagrelor 90 mg twice daily, the regular dose, 60 mg twice daily, the new dose, or the placebo. So all the patients had aspirin 75 to 1 free mg. So the beyond 12, the study duration was minimum of 12 months follow-up, but the patient received the drug up to 36 months, that means up to 3 years. And what was the primary efficacy endpoints that followed? The combined endpoint was CV death and MIR stroke. The primary safety endpoint, of course, was a TIMI-defined major bleeding. So what did Pegasus TIMI 54 trial found? That when combined aspirin with ticagrelor in patients with MI with at least one more risk factor high group, there is a significant decrease in the event rate, primary event rate, which is a combined CV death, MI and stroke. So this is an impressive confidence interval and a p-value. So this has paved way for the recommendations that ticagrelor can be given an extended DAPT as one of the drug, probably the only drug as on today accepted for the extended DAPT. This of course came with a little amount of high incidence of bleed. If you see when compared to the placebo, the bleed risk in this DAPT trial ticagrelor are high. Fortunately so, the fatal bleed, fatal ICH, the non-fatal ICH, and then these kinds of bleeds were quite less in ticagrelor group. So we are not increasing the fatal bleed. But of course, there are about 20 to 30% of withdrawal because of the bleeds, but the fatal bleeds were quite common and equal to the placebo. So Pegasus TIMI 54 has demonstrated that addition of ticagrelor 60 mg twice daily or 90 mg twice daily with low dose aspirin 1 to 3 years after MI in at least one more high risk substrate has significantly reduced the risk of primary endpoint of CV death, MI and stroke. There was a directionally consistent effect was observed in all components of the primary endpoint, including CV death. The benefit of ticagrelor was consistent among major clinical subgroups and by region and continued to accrue over a period of 33 months where it has been studied. And of course, the rate of primary safety endpoint, as I said, TIMI major bleed was higher in both arms, that is 60 mg, 90 mg. It was little lower numerically in the 60 mg twice daily group. That's the reason 60 mg twice daily group is now accepted for the DAPT beyond 1 year. And of course, as I said, the fatal or non-fatal IC bleeds has quite low, is less than 1% at 3 years and did not differ between the placebo arms or 60 mg BAD arms or 90 mg BAD arms. Dyspnea of course was frequent, and probably it was noticed that dyspnea was little more frequent in this Pegasus trial than the Plateau trial. So just a comparison, as I was telling, the DAPT was basically a trial where there is a patient who underwent a stenting, whereas the Pegasus trial is a MI patient with one more risk factor. The number of patients were quite high in the Pegasus trial. They are high risk group. There is a 1:1:1 randomization in Pegasus trial, whereas there is a 1:1 randomization in the DAPT trial. And then both trials has proved that beyond 12 months, the DAPT is going to be helpful, useful. But the data was robust with ticagrelor in form of Pegasus trial because of the quite impressive confidence interval and p-value and the number of events which are decreased at no increase in the bleeding rates and at increase in the bleeding rates but no fatal bleeding rates. That's what most of the European guidelines now suggest the extended DAPT beyond 12 months, only the ticagrelor to be used, either it may be in the ACS managed medically or it may be ACS PCI, it may be NSTMI PCI or STA PCI. So this is the only DAPT which is accepted as of now beyond 12 months. Even if the patient were to be on a clopidogrel or prasugrel in the past, it is the ticagrelor which has to be given preferably in a 60 mg twice daily for at least 3 years. Up to 3 years there is a recommendation. Beyond 3 years we need to probably stop because we don't have any much of recommendations as of now. We have only evidence up to 3 years now. So to conclude, ticagrelor 60 milligram twice only is the only P2Y12 inhibitor approved for extended use in post-MI patients, remaining at continued long-term risk. I wish to again remind the PEGAS trial, there are about 83% of patients who underwent stenting. It's not just a MI patients. And 63%, impressive 63% were having a multivessel stenting. So PEGAS is not a simple MI patient. There is a substrate, there is a good number of patients with stenting as well, including the multivessel stenting. So whom do I choose now with this evidence for a extended DAPT with ticagrelor? Recently, I did a multiple stenting to a guy who is 60 years old. I did the decay crush to the LMCA bifurcation, one more stent down in LAD and an LCX. And this patient unfortunately had a stent thrombosis on the second day. This patient had a GFR of 60 ml per minute, and then he is a diabetic requiring the medications. So this is the kind of subset I am talking. So we are probably looking at extended DAPT in the multivessel disease, multiple prior MIs, diabetes mellitus, and elderly people and chronic renal dysfunction who are more prone for the kind of stent thrombosis or event rates. So what we are going to do in these such kind of patients, I am going to see for the excluded contraindications, including the recent bleeds, and I am going to evaluate the patient's tolerance. For example, when the patient has took 12 months of DAPT rigorously and then religiously and then comes, then only I am going to give, otherwise I am not going to give. Why I am going to give, as we saw in the PEGAS trial, is going to decrease the combined CV death and MI and the stroke. Thank you very much for your patient listening.